Thank you. I really am impressed by the attendance this year. Thanks for coming and taking time out on Saturday to be with us. Hopefully while here at the breaks and at lunch, we'll get to talk and kind of meet each other. But we like questions, so when we get to the panel discussion, please ask many. I'm going to discuss a topic that we could probably spend 2 days on, and that's treatment of nontuberculous mycobacteria. Before I begin, just some disclosures. 2 research grants from these companies, Insmed and Sparrow, and serving on the advisory board of multiple companies that have, the good news, drugs that are in development to treat nontuberculous mycobacteria. So we're actually very excited that we have some engagement with industry now and interest. So I'm not going to go through all 200 species of nontuberculous mycobacteria. Oh, yes, I am. But I am going to give you just an example that there are many of them. So 200 species, believe that or not. That's amazing. These are some that have been reported to cause lung disease. And fortunately for the clinician, we don't have to know all of these names. It's really just a small number that we see on a daily basis. So those are the ones we'll focus on today. But typically you'll hear us talk about slowly growing and rapidly growing organisms. Now, as a patient, you don't want to hear that you have a rapidly growing anything. But they're not really rapid. It just means that they grow within about 7 days, but a Staphylococcus organism will grow in minutes. So compared to bacteria, they're still quite slow growing. But they're rapid when you compare them to MAC and some of the other mycobacteria that take over 7 days to grow. Now, I've bolded those that I'm going to focus on today. These are the 2 most common we see in our patients, pretty much worldwide. And in the slow growers, that's MAC, Mycobacterium avium complex. And I've highlighted 3, the 3 most common, avium, chimera, and intracellulare. If you've ever heard one of those mentioned, they're all called MAC, but they're different species. And among the rapidly growing, you'll see Mycobacterium abscessus, Belledii, and also Macilliense. These are all abscessus, but it turns out there are 3 subspecies of abscessus. So the ATS, the American Thoracic Society, and the Infectious Disease Society of America, a number of years ago, put together these guidelines. They're called diagnostic criteria, with the idea that clinicians need help in figuring out what to do when a patient grows an NTM. Because unlike TB, where if you grow a single organism, we treat you with a standard regimen, the same regimen everywhere in the world, we know if you grow an NTM, you may never grow it again. So just because you grow it doesn't mean it's causing harm. And even if you grow it multiple times, it doesn't mean it's causing harm. And this is the difficult part as a clinician for us to figure out. So these are the criteria that we use to try to help us put people into the disease category versus the not disease category. Recognizing that's what we do today, but next year or 5 years, someone may shift and move from the non-disease to the disease. So we start with clinical. We expect, as part of a diagnostic criteria, that the patient's going to have symptoms. The 2 most common, cough and fatigue, about 80% of people have that. Weight loss is common, but it typically is later in the course of disease. And these symptoms will lead to an investigation, and that would be a radiographic investigation. Most clinicians aren't going to think about NTM until they see an X-ray or till they see a CAT scan. And that's when they say, maybe I should send cultures. The top panel is what you often hear too as nodular bronchiectatic disease. And the little clusters of grapes on either side of the heart, those are areas of bronchiectasis. And it is that bronchiectasis that makes you susceptible to NTM in the first place. But there's another presentation, which is in the lower panel, and that's a chest X-ray. And we see on the right side of the lung, there's scarring up there, and there's cavitation, and that's called fibrocavitary disease. That looks just like tuberculosis. And often these patients come into the system because we think they have TB, but then the cultures that are obtained grow MAC, or abscessus, or Kansasii, or any of those species that I mentioned. But ultimately, this is an infectious disease, so we need cultures. And so it's critical that we get adequate cultures. The current definition says that we need 2 or more positive cultures from that patient. It doesn't tell us exactly, should they be on the 2 days apart or 2 months apart. There's some clinical judgment in that. If we can't get sputum from someone, then we'll do a bronchoscopy. And one bronchoscopic specimen is considered positive and therefore meeting disease criteria. But at National Jewish, we're very focused on trying to document bacterial load, so we want to see more than two in most cases. We like to see multiple positive cultures before we decide that it's time to treat you. So we go from clinical to radiographic abnormalities, but ultimately we want cultures. Now you come to clinic because you have 2 or more positive cultures, and I'm trying to decide, should you be treated or not? Well, this is tough. Those criteria are just a guideline. I still have to sit down and look at you as an individual and decide, should we treat you? So the things we look at are you. What is it about you that might make me say I should treat you versus not treat you? I have to look at which of those 200 species you grew and how much did you grow. That's going to help me make a decision. And ultimately, what's the goal of therapy? For some of these specimens or these species, and particularly in a very advanced disease, I may not be able to tell you I'm going to cure you. I'm going to try to control the infection and stop progression and improve your symptoms. So some of the other species I can cure almost all the time. So that'll be a different discussion, because in that case maybe the goal of therapy is cure, and let's talk about what we have to do to achieve the goal. So when I talk about the patient, I'm talking about, do you have an increased susceptibility? Do you have bronchiectasis, which is the greatest susceptibility for pulmonary NTM that we know? Are you symptomatic? If you come in and you grew MAC twice and you feel fine, I can't make you feel better with my medicine. I guarantee I can make you feel worse. So I have to, think about what's the goal here? You don't have symptoms. Maybe it's not the time to treat. But something that I think all clinicians use is the radiograph. If we see this black hole there, that's a cavity. That's lung destruction. There is nothing to wait for. It's already happened. This is time to treat. But maybe you don't have cavities, and that may push me the other way and say, well, you have mild disease. Maybe it's not time to treat. So looking at the factors at an individual level in the patient can be helpful. In the guidelines, we frankly don't say very much about the organism. How do you describe 200 organisms and make sense of that? But it turns out it's very important. What you see here is, let's call it a pathogenicity scale. So at one end, it's 0, meaning if you grow that organism, it never makes you sick. The other end is 100, meaning if you grow that organism, 100% of the time, it's causing disease. So we can actually, through some studies, plot the organism that people grow along this scale. So if we start at the 100%, if someone grows Mycobacterium sulgi, calatum, genovens, these are ones you probably haven't heard of. They're not as common, but they're very pathogenic. So if I see you and you're growing one of those, I'm much more likely to treat than not treat. But now let's flip to the other end of the scale, 0. Interjectum. I just saw someone recently with interjectum, Chelonia, Simiae. These are ones that are in water. And you may have just drank or showered in some and had a little bit in your airway, culture becomes positive, but these almost never cause disease. So the clinician does need to be aware of this. Where on this spectrum is the isolate they got from you? The hard part for us, look what's in the middle. Abscessus, avium, intracellulare, the most common ones, the ones that we as clinicians have to figure out, should we treat or not? So this is the difficult part. The ones we have to deal with clinically, commonly, are somewhere in the middle. And then I mentioned goals. So are we talking about cure? With some species, we are. With early disease, we are. Maybe we're not talking about cure. Maybe our first goal is to convert the cultures to negative, because that's associated with some improvement in your symptoms and slowing or lack of progression. Everyone who has symptoms, when I treat them, they want those symptoms to get better. So maybe that's our target. Let's get rid of your cough. Maybe let's see if we can get some weight on you. And then prevent progression. And the way we figure that out is usually radiographically. Is your CT stable over time? So these may be goals if we cannot achieve cure. If we are trying to achieve cure, I alluded to this earlier. So let's look at what would be the expected outcomes with 3 of the more common species. Mycobacterium kanzasii, it's one of the more common NTM, and we cure almost everybody. It's much like TB. We can cure it with oral drugs. We love kanzasii. We don't see many patients with kanzasii at National Jewish because the docs out in the community can easily cure it. MAC, we see a lot of. But now the discussion, when you say, what's my chance to cure, I'm going to tell you, well, based on studies, somewhere between 56 and 85%. And you go, why such a range? Well, it depends on extent of disease. People with cavitary disease have a lower cure rate than those who do not have cavitary disease. Those who have mild focal disease, they're going to be cured at a higher rate than someone who has it everywhere. With abscesses, look at this. This is a really broad range of cure, 25 to 80%. So this is somewhat also based on extent of disease, but more than any other organism that we work with, it's also based on which of the subspecies you have. So remember at the beginning, I said people have abscesses, but there are 3 subspecies, and we'll talk about that and its impact on treatment. So here we are, we're trying to balance risk and benefit. Undertreatment would potentially lead to my patients having progressive disease, but then I have to balance that against if I treat people who don't need to be treated, that's undue drug toxicity, undue cost. So we have to balance this for each individual. So let's talk about treatment, and we'll focus first on MAC and then on abscesses, but these are some general ideas. First, you can't treat this with one drug, not possible. If I give you one drug, it will develop resistance to that drug. So it requires a multi-drug regimen to enhance efficacy, but really to prevent the emergence of resistance to the drugs. They kind of protect each other. It varies by species, as I just showed, in terms of how we treat and what our expected outcomes are, and it is unfortunately frequently associated with adverse events. Treatment is long. Current recommendations are 12 months after the cultures become negative, so it's important that physicians are getting cultures regularly so that we can figure out when they become negative, and then we count 12 months. And treatment outcomes are suboptimal for many, but again, it varies by species. Very good outcomes for some, not so good for others. And for every one that we've kind of looked at in detail, which is MAC and abscesses, recurrence is pretty common. And reinfection is common, meaning you go out into your environment and you get it again. And I don't think we should be surprised about that, because one thing we don't get rid of when we treat and cure your infection is we don't get rid of the bronchiectasis. So the susceptibility you still have. And if you get exposed in your environment again, then of course you may get reinfected. So this is a very important area of research that needs to really fill in some gaps on how to prevent reinfection. So these are the drugs we use. We divide them into oral drugs, parenteral, which means intravenous or intramuscular, and now we have inhaled antibiotics, amikacin. And while maybe this list of oral drugs looks long, it's not very long. And we need more drugs. And fortunately, I think we have some that will be coming. The parenteral drugs, many of the ones that we use here, like imipenem, sulfoxetine, tigecycline, these were never developed for NTM. These were developed for other infections, but we're lucky that they have activity against some NTM, and so we borrow from other antibiotics. And it's really the same for amikacin, which we can give both intravenously, intramuscularly, or inhaled. So just to make this real, this is a 35-year-old Caucasian woman from Florida with cough for several weeks. She went to her provider who began an evaluation. And as part of that evaluation, she had a chest x-ray. And in this chest x-ray, in this area right here, there's some little increased density up in this area. And it turns out, after a CT was obtained, there's cavitation. So there's 2 cavities, these rounded areas. These are areas where the lung has necrosed. That lung will not come back. And those areas have a very high bacillary burden. So this is a person that kind of has an unusual presentation. This is a person who's young, did not have bronchiectasis, has upper lobe cavitary, which is usually associated with emphysema. And the point of this is, even though we give you these two examples of fibrocavitary and nodular bronchiectatic, there's a lot in between. And we're seeing more and more young people coming in with MAC and these infections. So this is part of the increase, is that we're seeing it spread outside our typical population that we've always thought about, which was older Caucasian women. Okay, so she had MAC. She grew MAC, and we ended up treating her for that. But I want you to know that when we use the term MAC, Mycobacterium avium complex, there are now 12 species of MAC. Most of you, probably some of your docs call it MAI. That's an old term. That's a term that came about when we knew there were two species, avium and intracellular, but there are 12 now. So the appropriate term is Mycobacterium avium complex. To be honest, the appropriate term is we should be just telling you which species you have. They're different species, and we don't know if they behave the same. In fact, there's research showing they may not behave the same. So we would prefer that the clinician and you know exactly which species. So this is the typical lab report we see in the US. The identification is the doctor sees Mycobacterium avium complex. They don't know which of the 12 species. They get drug susceptibility testing, and they may just have labeled R for resistant, S for susceptible, I for intermediate, and they may have a number attached to it which gives us some degree of how resistant or how susceptible. We think that what you should have is how many colonies you grow, how much are you growing. People who grow a lot are more likely to progress than those who grow a little bit. And this changes over time. And we think that they should be telling you which species you have. In terms of susceptibility testing, the MIC, which is kind of a measure of just how resistant or how susceptible, that should also be provided. And we shouldn't just say it's resistant and think that it doesn't work, because that is not how it works. It's a continuum. And there's not always a cut point where it just doesn't work anymore. Even when it says resistance, the drugs we use for MAC, like rifampin and ethambutol, you should still take those medicines. So people have to understand the limitations of what the laboratory can do. And really the only one we care about in someone who's never been treated for MAC is the clarithromycin. That's the one that will determine whether you respond to therapy or not. So you grow MAC, let's start at the top. The lab is going to tell us, is that isolate that you grew susceptible to the macrolides, either clarithromycin or azithromycin? And it should be if you've never been treated before. Then we ask the next question, does your CT scan show cavities or no cavities? If there are cavities, we're going to recommend you take a 3-drug regimen and you take it every day. If it's non-cavitary, we may say, we want you to take the same 3 drugs. We may adjust the dose a little bit, but you can take them 3 days a week, Monday, Wednesday, Friday. That's associated with less side effects, but the same efficacy, same outcome as daily therapy, but not in the setting when there's cavities. In the setting of cavities, 3 times a week does not work very well. Now, if you're unlucky and you've been treated before, your isolate may have become resistant to the macrolides. So in that setting, which is here, we can't use the macrolides. So we're going to have to find another drug from this little group. It's not a long list, but things like clofazimine, moxifloxacin, Cipro, these are common antibiotics used to treat respiratory infections. Some things you may not have heard of, bedaquiline is a TB drug. Maybe we'll recommend inhaled amikacin or even some other drugs we may come up with. If you have cavitary disease and or resistant disease, we're probably going to tell you we need to put a PICC line in and start IV amikacin for a couple of months. Because IV amikacin is one of our best drugs. It just doesn't come in a pill, so we have to give it to you either IV or inhaled. We treat for 12 months until the cultures have become negative. This is how every doctor in the United States, Canada, most of Europe, should treat you, following guidelines. And if they do, this is what we're going to tell you to expect. If you have an isolate that is macrolide susceptible and you have no cavities on your CT, we should be able to convert you at about 80%. If you have cavitation, it may drop, and it's ranged from about 50 to 80%. If you have macrolide resistant disease, this is tough. Now, if we don't do lung resection of the worst part of your lung, give you one of those aminoglycosides like amikacin for a long time, it drops from 80% to 5%. So this is one of the tougher things we have to deal with here at National Jewish. With my colleagues in Korea, we showed we could get it up to 15% if we did some surgery, gave some people amikacin. And if you do resectional surgery and you give 6 or more months of IV or intramuscular aminoglycoside, people have gotten it up to 80%. But it's a big cost to the patient. You lost some of your lung and you might have lost some hearing from having to get this for a long time. So our message to clinicians is don't create this resistance, and that is done by giving you a week regimen. And that is a critical thing, a message that we try to send out. So now what happens? I've cured you. Let's say you had non-cavitary disease, 80% chance now you're cured of this infection. What happens over time? There are 3 pretty good studies now that have looked at 150 to 400 patients here in the US, in Texas, in Chicago, and also in Korea. And if you follow people whose cultures became negative, how many become positive again? In Texas, 50% of the patients, they became positive again. Northwestern in Chicago, 25%, and in Seoul, Korea, 29%. And then we have techniques now. We can look at the kind of the genes, like a fingerprint of the organism, and see if it's the same one you had the first time. And it turns out doing that anywhere between 50 to 75%, it's a new organism. You went back out to that same environment where you were infected, where we don't know where you were infected. Dr. Honda and others are going to try to figure that out for us. But this is a really important thing. And this is why we harp on airway clearance. Keep those lungs clean. If you go out and inhale this organism somewhere, get it out. Don't let it get established. And the final thing I'll say about MAC is this is something we're learning. So this is a patient, 62-year-old, had fatigue and cough, had some mild bronchiectasis, and grew MAC, which we identified was specifically avium. And we started on a 3-drug regimen. And then we did what I want your clinicians to do, and that's check the sputum regularly. Just as I expected, she converted. We got rid of the Mycobacterium avium with a standard regimen, but we keep looking. Oops, there it was again. Okay, that happens. That's not so bad. It may still go away. And it did go away. But then, wait a minute. Chimera Yonganense. Then it was gone. Oops, there's Yonganense. This is what we're learning. We have molecular techniques now that we can tell so much more about the species. So this person is an example of things we see. People can be getting infected or reinfected, even on therapy. So we did cure her of what she came for, and then we learned in her case something was happening. Was it reflux that was happening? Was she living in a very high-risk environment? The answer to that was yes and yes. So we'll see. We've intervened, and I hope that this has stopped. So MAC disease should be treated with a macrolide-based regimen, and if it's macrolide susceptible, outcomes are excellent. If an aminoglycoside is used, it's usually in the setting of cavitary disease and macrolide-resistant disease. The optimal duration of therapy is really not known, but the guidelines say 12 months beyond culture conversion. Macrolide-susceptible MAC is usually cured, but there are recurrences. They're common in reinfection. And there are patients who they have refractory disease, and for that, we now have an FDA-approved drug, which is inhaled amikacin. Liposomal amikacin, and in refractory cases, our patients who are still culture positive after 6 months, we are now routinely recommending that that be used. But that's on top of your oral therapy. So it's an add-on, and usually we make that decision about 6 months. So let's move on. 68-year-old woman with chronic cough and fatigue. You can see multiple cavities on the CT scan and the X-ray. Much like the first patient, they thought she had tuberculosis, started her on TB therapy, isolated her at her home, but she ended up growing Mycobacterium avium complex and abscessus. We treated her for both, 5, 6 drugs to get both. MAC was cured, never saw it again. We never got rid of her Kansassii because it was so extensive at the time she presented. And we're not going into detail on this slide, but it's just to depict that you may be confused if you have abscesses, what kind of abscesses you have, and your doctor may not even know there are different kinds of abscesses. And it's partly because in science, this has been changing. In 1953, abscesses was isolated from this person's knee and buttocks, where they had abscesses in the skin, but it wasn't named until 1992. And then in 2006, a team of scientists started using sequencing, looking at the genes. And they said, abscesses is not just abscesses. There are actually 3 forms of abscesses. And they named 3 species. It has now evolved, again, with science and some different analysis, that we think those are subspecies. So the bottom line today, we say that there are 3 subspecies of abscesses. Abscessus subspecies abscessus, abscessus subspecies massiliense, and Belledii. And it's very important, as you will see, to know which one you have. Because just like with MAC, the macrolides are the most important drug class that we have. We know abscessus is just an organism that happens to be a very resistant organism. That's why it's hard to cure. But there are 2 types of resistance. One is a mutational resistance. This is the same thing that occurs with MAC. A gene mutation occurs and it doesn't work anymore. And it's very easy to find that mutation. We have a test here that we can tell you that in 24 hours of getting growth. But what makes this difficult is what's called inducible resistance. So the lab will check the resistance at about 3 days of growing it on the agar plate, and they'll say, it's susceptible, great, use the macrolide. But now we know this organism has a gene. And when you expose it to that clarithromycin or that azithromycin, the gene turns on. And by 14 days, it's not working anymore. The macrolide is no longer working. So we say that the resistance was induced. So the lab has to tell the physician this, or they're not going to treat you correctly. And it's complex. And this is just to kind of give you an idea of the complexity of what clinicians now have to understand from their laboratory. They're going to know, for example, which species it is in some labs, but most labs in the US will not tell you the subspecies, so they don't know. They just are told it's abscessus. Well, they need to know, because each of these different species can behave differently. Some almost always have inducible resistance, and that would be Mycobacterium abscessus. 85% of strains of abscessus have inducible resistance. If you have, however, massiliense, that gene has a mutation and a big piece of it is missing, so it doesn't work. So then the azithromycin works. We want to give you the azithromycin. But when it doesn't work, we probably should be looking for other drugs. So it's a very complex thing, and unfortunately, laboratories are not telling clinicians this information. So kind of like we saw with the MAC, the common report will say, well, this is Mycobacterium chelonia-abscessus group. Well, that's 2 different species, Chelonia and abscessus, so your doc now is totally confused, and there's no subspecies designation. And then they'll give them the I's and the R's, and they don't know what to do with the I's and the R's. They should find out how much you're growing, 5 colonies, 200 colonies, is it M. abscessus, and which subspecies is it? That is important, because in the next few slides, I'm going to show you, totally changes your outcome. And then the susceptibility data, again, should be very precise, providing these MIC numbers, because just saying it's resistant or susceptible is inadequate for the doctor to be able to make a decision. So here we go. M. abscessus, you grow it. I'd like my lab to tell me, and ours does, of course, which subspecies it is. If you grow abscessus or Belledii subspecies, that usually means it's not, the macrolide will not work. And so I put a question mark by the macrolide. Maybe we should give it, maybe we shouldn't, but we shouldn't count on it. So I'm going to have to find 2 or more other oral drugs, and I'll show you we don't have a lot. We usually start amikacin, usually intravenous, sometimes inhaled. We give the IV drugs for about 2 months, sometimes longer, and then we put you on what we call a holding regimen, something to maybe cure, but definitely we want to stop progression. And at this stage, we'll often switch from intravenous to inhaled amikacin. If you grow massiliense, or in some strains of abscessus, that gene, that ERM41 gene, is not functional. Hallelujah. You can use the macrolide. And if you do that, now I only have to find 1 or more oral drugs, so it makes it a little easier. Otherwise, we treat pretty much the same. And the problem with abscesses is we have to use IV drugs for some of the therapy. These same drugs I mentioned earlier that we use to treat bacterial infections, we use to treat abscesses, but we also will need some oral drugs, and we don't have many. We have clofazimine, linezolid, moxifloxacin, bedaquiline, a few others, but we don't have very many, and there's very little data. That's why if you come to a place like National Jewish, we'll probably put you on a drug that no one's even mentioned to you, because these are used so rarely outside of an institution like us. So here's why it's so important to know. So these are 4 studies, they're small studies, but what they were able to do is do gene sequencing and tell the clinician, you have this subspecies in that patient versus this one. So abscessus or massiliense, here's what I want to focus on, sputum conversion, a measure that you got better. So you look all the way down that column. If someone grew abscessus, the cure rate or conversion rate was 25%, 42%, 25, 26. So 3 of the 4 studies, different places, found the same result. If you have true abscesses, that macrolite's not working, and we have a real hard time converting people. But if you have massiliense, means that macrolite is working, 88, 96, 86, 82% conversion. That's unbelievably different. And yet most laboratories in the US do not tell the clinician this information. So I think that's terrible, because it is easily available. So M. abscessus, tough to treat because it's very resistant. It's not a superbug, just resistant to so many antibiotics, but we can treat it. We have to use a combination of intravenous for a few months, oral, then inhaled antibiotics, usually amikacin. Treatment outcomes depend on that ERM gene status, so the laboratory has to tell the clinician this information. You saw what happens. If the ERM gene is not working and that macrolide is working, that azithromycin, very different outcome. And I didn't go over this, but just like MAC, recurrences are very common. We still see recurrences pretty commonly, even after culture conversion. Surgical resection is something we consider in any patient who has abscessus and very focal disease. If our cure rate is 25%, that's suboptimal. But just like with MAC, if we do surgery on the right patients, we can significantly increase that cure rate. But it requires surgery, and it still requires an aggressive approach to treatment to be able to cure this. So with that, I want to remind you, as I started, new drugs are coming. There are multiple companies that have drugs that are active, more active than many of the drugs we have today. So we're going to support them in that development so that we can try to get our patients these better drugs so that those cure rates continue to climb. So I thank you for your attention.